All right, I started a recording because if you guys have noticed, every week I've been posting the recording from class onto our announcements in Canvas. So that's going to be the same today. I'll have this posted down probably by the end of the afternoon. It doesn't take me too long to get that uploaded. Okay. A few announcements before we jump into the content and before we look at like your assignments and stuff that are due this week. This is my last week with you guys. I'm going to be going on maternity leave starting next week. So until like Sunday, I'll be available to you guys with any questions, unless of course I'm like in labor or something. But next week, you guys are going to be in with Professor Luminoso. Okay. So she is going to be taking over this section. Um, she will be posting her Zoom link for you guys. She'll be posting like how she usually formats her class. We met at the beginning of the semester and she plans on keeping it very similar to what we've been doing in class already. So it shouldn't be too big of an adjustment for you guys. But just be on the lookout for any announcements from her coming into your Canvas, uh, and any email that you may receive from her. Okay. So next week, Professor Luminoso is taking over. You'll be with her for the remainder of the semester. Okay. Um, I sent emails to any of the students who scored below a 78% on the exam or who overall have a less than 78% KGA in the course as of right now. Please check your email. I'm trying to set up meetings with as many of you as I can before the end of this week, just so we can keep it consistent. And that way I don't have to email Professor Luminoso with too many students and like kind of overwhelm her right when she's taking over this section. Okay. So if you received one of those emails, or if you even just want to go over your exam, like if you did really well on your exam and you still want to go over the things you missed, because like this stuff is going to be on your HESI, it could also potentially be on your NCLEX, right? So if you want to review your test, if you want to meet with me over anything, just email me and we'll set up a time to meet and we can go over the exam together. Okay? I believe everyone has taken it from all the other sections. I know there were a couple of students who had to make them up from other sections, but as long as everybody is done and has tested, we can go over those exams. Okay. Does anyone have questions so far about anything? Cool. All right. So let's go into Canvas here, see what we have due and what's coming up for us. Alrighty. So looking in Canvas here, we're in week 5 already, which is kind of crazy. So you guys have your second OB math calculations assignment that is due. That'll be due by Sunday. Like last time, if you guys want to send me the work that you do whenever you're completing these assignments, please do. I'll review it. I will put in the comments whenever I'm grading the assignments on Monday, the solutions to the problems that you missed. Okay. If anybody is having extra trouble with math, please reach out and we can schedule a meeting and we can do some practice problems and stuff together. Math calculations is something that is you're going to be doing for your entire career. Obviously, it's going to be on your NCLEX, your HESIs, all of that. But this is stuff that we need to make sure that we understand. Okay. Math calculations do not go away. So take your time, work on that. And then you also have your SIM chart preeclampsia assignment that is due by Sunday. Okay. um, like I mentioned in weeks before, if you complete the like if you complete any of your sim chart assignments late, within that 1 week grace period, that is fine. Just send me an email because I don't go into Evolve every day and look to see if you've completed the assignment. So, and it doesn't pull over if you turn it in after the due date. So you have to let me know that you've completed it. Otherwise, I will not see your grade and it'll be a 0 in the grade book. Okay. So just send me a message and also let me know, like, hey, this is why I turned this in late. This is, just a little communication is necessary for me to be able to give you credit on the assignments, right? That is this week. Next week, you have quiz number 4 at the start of class. Okay. So, like today, we got that quiz started at like 9:02. So, you guys see how it usually goes. Like, you guys come in, I say, hey, what's up? And then we go right into the quiz. Okay. That is going to be the same for quiz 4 with Professor Luminoso next week. Quiz 4 content is going to cover stuff that we are going over this week and also stuff and content from week 6. So make sure you guys are listening to the recorded lectures. Make sure you're looking at the PowerPoints with the content prior to coming to class. That way you are understanding and have a base knowledge of the stuff that we are going to be covering during class time. Okay? Next week, you have another sim chart that'll be due, and then you have your NCLEX questions due. I had a couple of students who turned in incorrect versions of the um, document for NCLEX. So let's go into that really quick so that I can show you guys where it tells you and how to download it. So here, if you're in here under the assignment, when you've completed all 50 questions, select End and Tally Session, select Exam Results to be submitted, and then select Print Results, and then you save that as a PDF. So you save that file that pops up whenever you say Print to your computer as the PDF, and then you're going to upload that into Canvas with this heading. And then that's all you have to do. Okay. I had a couple of people who sent me screenshots. I had a couple of people who sent me like a different screen, like a picture on their phone. Like, we can't accept any of these simply because of like cheating, continuity of grading. We have to keep it standard across the board. Okay. Um, for the first week, I allowed people to resubmit. If you resubmitted it incorrectly the second time, I still gave you a 0. For this week, if you submit it incorrectly the first time, you're going to receive a 0. And we are not supposed to allow students to resubmit it for the second assignment. Okay. So just make sure you guys are reading the instructions really thoroughly whenever you're completing any of your homework assignments, because I don't want you guys to not get points on things that are so silly and simple, right? Okay. Um, so that is what we're doing this week. That's what you guys will have coming up next week. Okay. Week 7 is our Unit 2 exam. So exam 2 is in week 7. So during week 6, you guys are going to have the opportunity to join those review sessions again. Okay. It'll be exactly like the review sessions for exam 1. You'll get an announcement that have all the dates and times of all the professors' review sessions. And I encourage everyone to try and attend at least one of them. Okay. All right. So let's go into the announcements because I had a couple of questions about the announcements page over the weekend. All right. So going in here, this is the welcome to week 5 because I had some students reach out and ask where they can find my recorded lecture. Okay. So this is where you go. All my announcements have the link to my YouTube recorded lecture here. They have the PowerPoint that's accompanied with the lecture. So what I would encourage everyone to do is print out the lecture PowerPoints and then take notes on it as you're listening to or watching the recorded lecture. Okay, that I think is the most effective way to get all the material that you need. We cover the big things in class. As you guys have probably caught on by now, we go over the major concepts. We are not covering every little thing that you could potentially need to know on your exam. We go over the big ticket items and then we kind of are reviewing past that. Okay. So for those of you who are not sure where to find my recorded lecture, they're always going to be in the weekly announcements with this link. as well as access to the PowerPoints that I made for you guys. Okay? Any questions on our homework? Any questions on Canvas or looking in the announcements or modules, anything like that? Awesome. This is week 5. We're almost halfway through the course. So if you guys are still struggling to find the material or like still struggling with just like overall keeping up with like content, please schedule a time to meet with me and we can try and do some type of organization or brainstorming to help you because I don't want you guys, I want you all to be successful. So however I can help you, I want to help you. I'm on a bit of a time crunch because hopefully this baby decides to come out of me sometime soon. That'd be great. But I want to help you guys as best as I can before I go on leave, okay? So don't hesitate to reach out. So our plan for today, we're going to go through the classroom PowerPoint that you guys all should have had access to. Um, we have a lot to cover. This is like the high risk perinatal care section. And exam 2 in the past has been the one that students have had a harder time with because of the amount of content. So I want us to spend a good amount of time today going over the content with this because it's very important and you'll see a lot of it on exam 2. Okay. Um, if we have time at the end, which I am anticipating we might have a little bit, we will play some Kahoot review games that covers content that we went over last week and then content from this week. Okay. Since I will not be around to do the exam 2 review, um, if we have time, I'm going to do my exam 2 review Kahoot with you guys so that we can start kind of like preparing for that exam. There will be some content on there that you guys haven't seen yet because it will have stuff from next week on it. But in my opinion, any review is good review. So we're going to jump right into it here, okay? If you guys are good with it, I was not planning on taking a break today and just letting you guys out 15 minutes early if you guys are fine with that. Awesome. I'm seeing head nods. Okay. So that's what we're going to plan to do. Obviously, if you have to get up and go to the bathroom, whatever, just shoot me a little message so I know why you're coming off screen. But we'll get it started. I might run to the bathroom really quick here, so just give me like 2 seconds and then we'll get going, okay?
We can't hear you.
All right, let's go ahead and jump into the PowerPoint from this week. So if everybody has their copy that they have access to, go ahead and pull that out. We're going to get started here. All right, so let's do a little bit of review. So, what are some things that we can do as the bedside nurse to manage uterine atony? First of all, someone tell me what uterine atony means. What is this like kind of just another word for?
Isn't that like when the uterus is boggy,
Yes, we
like
have a
not
boggy.
contracting?
Yes, our fundus is not firm. So, with a non-firm fundus, what are we worried about? What is probably happening with this patient?
Maybe
Yeah, she's hemorrhaging. So uterine atony just means what is the tone? What is our atony of our uterus? Is it firm? Is it boggy? If we have a boggy uterus, what can we do to correct that? What are some big things?
massage,
Massage. Yep.
oxytocin.
Yep. We can administer medication. One more. We can manage our bladder. Okay. So last week we talked pretty extensively about how a bladder, a full bladder, can get in the way of a uterus and will not allow it to completely clamp down and will not allow it to contract, which would lead to a boggy uterus and increase the mom's chance and risk of a postpartum hemorrhage. Okay. So here are the things that we can do as the bedside nurse. We can massage our fundus, manage the bladder, and give medications. Another way to remember that is fundus Foley Pitocin. Okay. When we massage the fundus, we always have one hand underneath at the base of the fundus and one hand at the top of the fundus. This bottom hand is providing support because if you push really, really hard on the top of a fundus, you have the potential of completely inverting that uterus and like sending it down and out through the vagina. This is not common, okay? I think I've only seen a uterine inversion like that happen like one time, and it was whenever the placenta was being delivered. But that's the reason why we're putting our hand down on the bottom of that fundus is so that we don't have it doesn't invert on us or we don't have a prolapse, okay? And then it also just helps with adding contraction to that muscle and allows it to firm up. All right. We talked about managing our bladder. That bladder, if it gets full, it's going to displace our uterus. So our uterus is going to not be midline, it'll be off to one side or the other. All right. Because we know that a good fundal assessment, the fundus should be midline, should be firm, and it should be at the level of the umbilicus. Okay. So those are that's our normal postpartum assessment for a uterus. Okay. So besides Pitocin, what are other medications that we can administer to a mom to help with uterine contractility, to prevent uterine atony? There's four of them.
The hemabate,
Hemabate.
Methogen, or however you say it.
methogen,
Perfect. Methergen. You got it. And then there's
the misoprostol, I think.
misoprostol. Yes, excellent. That the other word for it is Cytotec. Okay. So all four of these medications can be used as a line of defense against uterine atony. All right. Um, the there are times where you will administer all four of these medications. All right. If it's a really bad postpartum hemorrhage and mom is bleeding and we can't get it to stop. So there is not really like it's provider discretion. If you're administering these medications, your doctor should be at the bedside and in the room with you, especially if you're giving all four of them, right? Because that's a pretty bad hemorrhage if you're giving all of those meds. With hemabate, who are the patients that can't have that medication?
Asthma,
Asthma,
Asthmatics. Yep, people that have asthma. And then with methergen, who can't have that?
hypertension.
hypertensive,
Yes, patients that have high blood pressure. Okay. Um, so you guys need to have a really good understanding of these concepts going into exam two. Okay. But these are the three things that we can do to manage uterine atony. We went over these already. The four uterotonics used to stop uterine atony: Pitocin, Methergen, Misoprostol, and Hemabate. And you guys will definitely need to know um, when the patient can't have hemabate and when they can't have methergen. Okay. I had someone ask at the end of class last week, which was a really good question, if Pitocin was only administered an IV. Oxytocin can be administered as an IM injection as well. Okay. It's not the preferred route, and I don't honestly see a lot of providers administering it this way, simply because they want it to be a little bit longer acting. So they usually will hang it as an IV drip that goes over an hour to 2 hours. But if a patient doesn't have an IV, say she came in, she was a precipitous delivery. She came in and had her baby in 2 minutes. It was an RN delivery. And you just need to administer oxytocin. We're not going to be fumbling and bumbling around trying to start a line. We're just going to give her that 20 units of IM Pitocin, usually in her like thigh area. Okay. So Pitocin can be administered as an IM injection. What are some signs and symptoms of hypovolemia if we have a patient who is hemorrhaging?
Low blood pressure.
Low blood pressure. What will their
Dizzy and lightheaded.
dizzy and lightheaded? Excellent. Yes. What will their skin look like?
Pallor.
They're going to be pale, maybe a little
Cool, clammy.
sweaty. Sorry, what was that?
I was just saying like clammy.
Yep, clammy. hmm Are they going to be like talking to you like normal?
No, they're like lethargic.
They'll be lethargic. They'll maybe not be completely alert and oriented. Um, and their heart rate's going to go up. They're going to be tachycardic, okay? So you guys need to know these. The signs and symptoms of hypovolemia that's associated with excessive bleeding or a postpartum hemorrhage. Your patient is going to be tachycardic, okay? Their heart rate can get as high as up to like, I don't know. I've had patients before in like 180s, like they're low key in SVT, okay? Hypotension, their blood pressure is going to drop and it's going to drop very, very quickly, okay? That's why whenever we have a patient who's hemorrhaging, we are getting their vital signs at the minimum every 5 minutes. Okay. Sometimes if it's extreme, we're getting their blood pressure every minute because it's going to be dropping that rapidly and we need to have accurate readings.
I'm gonna just play mine out loud.
They are not going to have adequate urine output. They're going to have very minimal urine output. They are going to be pale, cool, clammy, dizzy, and very confused. All right. And like I said, these can happen like extremely rapidly. So they could be sitting up and talking to you 1 minute, and then the next minute almost be passed out and confused and showing all these signs and symptoms. All right. What is our typical recovery period for a standard postpartum delivery? How long are we usually with these patients for?
48 hours.
So sorry, I should have worded this differently. How long are we like doing vitals every 15 minutes or 30 minutes with fundal massages every like 15 minutes usually?
For 24 hours.
So usually our immediate recovery period is that first 2 hours after delivery. This is when we're doing like Q15 vitals, Q15 fundal checks. Um, After that 2 hour recovery period, as long as everything looks fine, mom's fundus is firm, her vitals are stable, we go to assessing them every 8 hours, as long as it's appropriate. Okay. But that 2 hour immediate recovery period is so important because that is most of the time when these signs and symptoms are going to occur, when this patient might bleed. Okay. That does not mean that you don't occasionally have that outlying patient who goes home and a week later has a postpartum hemorrhage. Okay, it happens. So that's why we extensively educate our patients before they go home so that they can know the signs and symptoms, the warning signs to look out for. All right. If the client shows signs of hypovolemia, but our fundus is firm, what other possible causes should we look for?
Hemorrhaging?
So we are worried about a hemorrhage still, but we want to know for this question, what could the source of our hemorrhage be if our fundus is nice and firm? If our uterus feels firm and it has good tone, we're not worried about uterine atony. So where else could this bleeding be
Like
coming?
a laceration,
Yeah,
Operation?
an unrepaired laceration. What else?
fragment to the left behind of the placenta.
We could be worried about retained product. Uh-huh. Yep. Another one could be a hematoma. Okay. So if your fundus is nice and firm, there is still a slight chance that bleed could be coming from the fundus, but it's not as likely. Okay. We're worried more about perineal lacerations, or worse, a cervical laceration that was not repaired. And then potentially a hematoma, which is just that pocket of blood or fluid that can collect in the perineum or the vagina, that is going to be very painful for the mom. If we, like signs and symptoms of a hematoma, mom would not be able to sit very well. She'd be extremely uncomfortable. She'd be complaining of excessive pain. So that's why we look and we assess the vagina every time we're performing an assessment, because we want to make sure that there's nothing that the provider needs to come in and correct or potentially like repair. All right. What education should we provide for a new mom concerned about how to identify postpartum depression?
I mean, you would educate them that the baby blues is a normal experience, but if it lasts over 3 weeks or after 3 weeks,
Two, you're
then
close. Yeah.
okay.
Yes, that's excellent. Yeah, postpartum blue, the baby blues are normal, but if it lasts longer than like 10 days to 2 weeks, we're worried more about postpartum depression. What else do we associate with postpartum depression most of the time, too? So for your exam, guys, you'll need to know difference between postpartum blues, like baby blues, postpartum depression, and then postpartum psychosis. So let's run through each of them here real quick. We'll do the Spark Notes version. Postpartum blues is when moms are just extremely emotionally labile. All right. They're going to have those very drastic changes in mood. They'll cry randomly over things that may not normally be as big of a deal to them. Um, they'll just feel more anxious. Some people report feeling like their heart is racing, like they're having like anxiety attacks. Those types of things can be normal for most moms, up until 10 days postpartum. The biggest difference between postpartum blues and postpartum depression is whenever is the onset and how long it lasts. And then also with postpartum depression, moms don't feel like they want to bond or attach with their baby. So these moms that are experiencing postpartum depression are the moms who get extremely overwhelmed by the crying after 2 weeks that they just cannot be around their child. They don't want to take care of them. They're not taking good care of themselves. Um, so they're coming in disheveled. They're coming in not showered. They're not like paying attention to personal hygiene. They're not taking care of their lacerations or their surgical incision properly because they cannot get themselves to do it. Um, so postpartum depression is more serious in the fact that these moms are almost like not wanting to attach and bond with their newborn. With postpartum blues, the moms are still wanting to constantly be with their baby. They're still feeding, they're still doing all the things that they need to be doing. Um, they're just more emotional. With postpartum psychosis, these are moms that are having suicidal thoughts or suicidal attempts. Okay. They are hallucinating. They aren't sleeping. They're having the extreme highs and the extreme lows, almost like manic bipolar disorder. So it goes in stages based on severity. Okay. Uh, so with our answer here, what we should educate our patient on is contact the clinic if symptoms are worsening, lasting longer than 2 weeks, if they're detaching from the infant, or if they're having thoughts of self-harm. Okay? Those are the big red flags that we're going to need to tell our patients about. All right. What education would be helpful for a mom who's diagnosed with mastitis? How,
Keep feeding on that side.
yes, excellent. She's not going to want to hear that. That sucks, but you got to keep feeding on that side.
I don't know, like warm compress maybe
Yeah, a warm
to
compress.
alleviate the pain.
Yes. How does mastitis present usually?
Painful, fever,
Flu-like
like
symptoms.
Flu-like symptoms?
like yeah, like the pus from
Yes.
the nipple.
They'll have weird discharge from the one side. They are going to have like a redness or a hot patch on their one breast. Yep. So, heat, like you said, Sierra, heating before feeding to help empty the breast completely. Wear supportive bra. Feed on the non infected side first if it's painful. Oral analgesics and then antibiotics. All right. But yes, mastitis is going to present like they get really sick and it happens very quickly. We talked about that last week a little bit, where a patient could be perfectly fine in the morning and then have these flu like symptoms, body aches, chills, all of that, like very quickly. So we need to educate our patients on this and what to look out for. Oftentimes, mastitis will occur from a clogged milk duct and it'll just like keep getting worse and worse and worse and worse. So that's why we educate our moms on fully emptying the breast, ensuring that baby is getting an adequate feed. If the baby doesn't feed for a long time on one side and you still feel engorged, to pump to get all of that milk out. That way it doesn't back up and clog the milk ducts and lead to mastitis or something, some other type of infection. Okay. So education with all of these things is very important and something that we have to make sure we're doing as the bedside nurse before the patients are discharged from the hospital. Okay. Anyone have questions over these items that were reviewed from last week? Still with me here? Perfect. All right, let's move on. So, a big concept that we talk about in high risk perinatal care is going to be the difference between hyperemesis gravidarum and just normal nausea and vomiting during pregnancy. All right. So we're going to run through these things, and I want you to tell me if you think it is just normal signs of nausea and vomiting, or if this is hyperemesis gravidarum. All right. So we see in the middle here that with both of these, patients are going to have a distaste for certain foods. Food odor can trigger both of them, and that they can have nausea at any time of the day. All right. But let's see, what with vomiting that causes severe dehydration, would that be normal or would that be hyperemesis?
Hyperemesis.
Parameter.
Hyperemesis, yes. Causes ketonuria.
Hyperemesis.
That's going to be hyperemesis. If we're throwing up and dehydrated to the point we're going to start having, oop, I don't know what just happened. Oh, there we go. Okay. We're going to start having the ketones appear in our urine. Causes electrolyte imbalances.
Hyperemesis.
Hyperemesis. Vomiting that allows you to keep some foods down.
Normal.
That is normal. Causes nutritional deficiencies.
Paramesis.
Hyperemesis, correct. Vomiting that does not cause severe dehydration
Normal.
will be normal. Persistent vomiting causing weight loss.
Hyperemesis.
And then nausea with severe vomiting,
Hyperemesis.
and then nausea sometimes with vomiting.
Normal.
Yes, awesome. So the biggest takeaway with the difference between normal nausea and vomiting and then hyperemesis. Nausea and vomiting during pregnancy is a normal thing, especially in the first trimester. That's something a lot of women experience. Okay. But with nausea and vomiting in pregnancy, this is typically at a certain time during the day for most women. It goes away, and they're still able to keep down food, some beverages. Okay. These women with normal nausea and vomiting are not having severe electrolyte imbalances. They're not having any ketones in their urine. They're not losing a bunch of weight. They're not having nutritional deficiencies. Hyperemesis gravidarum is an emergency in some cases. Okay. These are women who will throw up every hour of the day, no matter what they're doing. If they're taking in any food, they're probably not. They're not keeping any fluid down. They're not keeping water down. They're unable to keep anything down in their stomach. So, this is leading to severe dehydration, extreme electrolyte imbalance, weight loss. These women typically have to come in and they have to get IV fluid replacement. Okay. And then they are usually monitored overnight and they're given Zofran every 4 hours. And sometimes even the antiemetics are not helpful in this case. Okay. Nausea and vomiting during pregnancy, normal nausea and vomiting during pregnancy, typically only lasts for the first trimester. And then usually women say, like, if they puke again, it'll be like once in a blue moon. It's very few and far between. Hyperemesis gravidarum can happen throughout the entirety of somebody's pregnancy. It doesn't go away with the first trimester. So it can happen throughout the entire pregnancy, which is really, really sucks. All right. Um, if it's bad enough, sometimes these women are women who stay in the hospital and are under observation for prolonged periods of time, which, as you can imagine, is very stressful and scary for these patients. All right. So hyperemesis gravidarum, those are the biggest things I want you guys to take away from it is that it causes severe dehydration, causes electrolyte imbalances, and nutritional deficiencies. And these women most likely need to have medical intervention to ensure that they are remaining healthy. Okay. Any questions on this? All right. So, what would we anticipate the treatment plan and education to be for a patient with hyperemesis gravidarum? Things that can help these patients.
Like fluid and electrolyte replacement. So like
Mhm.
IV fluid.
Yep, we might need you to come into the hospital and get IV fluids.
Nausea medication.
Nausea medication. Yep. Some patients, like you said, Alexis may get that pump, a Zofran pump, depending on how bad the hyperemesis gravidarum is. What would be our education on like how to eat or how to try and drink?
Small amount.
Small, frequent meals. hmm
hmm Like alternate between fluids and solids. Don't do both at the same time.
Yes. Excellent. So we're going to tell them to eat dry, starchy, easily digested carbs on awaking and when nausea occurs. All right. Saltine crackers, like toast, things that are very, very bland, that are easy to digest immediately whenever they wake up and whenever they start feeling nauseous. Small, frequent meals, like we mentioned. We don't want them to eat fried, acidic, or fatty foods. All right, this is going to make their nausea and vomiting much worse. They're going to irritate their stomach lining even further. They can try wearing those motion sickness wristbands. Some patients may want that Zofran pump or a patch, or they may just be getting promethazine or Phenergan every 4 to 6 hours throughout the day to try and help with their symptoms. So the anti-nausea medication. Herbal tea or ginger tea can sometimes be effective for some patients, but we want them to be cautious with these because any amounts of herbs, especially in the first trimester, we need to be careful with because sometimes these herbs can lead to other type of electrolyte imbalances or other type of like things that can occur. Um, So, like with ginger, that's one of those things that is a naturally occurring blood thinner. Ginger, ginkgo, garlic, and ginseng, I think. This is taking me back to like farm. I forget. Those four medications can sometimes interfere with our blood clotting and amounts. So if we have a patient who is anemic or is having any other type of clotting issues or whatever, or bleeding disorders, we want them to be careful with these herbs, especially in that first trimester. Okay. So we tell them and encourage them to drink herbal teas that are safe in pregnancy, but just in moderation. This isn't something they should be doing around the clock. Okay. Um, Avoid sudden movements. Get out of bed slowly. Suck on a popsicle if vomiting on an empty stomach. Cold foods are better tolerated typically for these patients. Alternate food and fluids. Remain upright after meals. And then come in and get IV fluid if needed. All right. With these patients, like if they tell you and they come in for an appointment and they tell you, like, the only thing I was able to keep down today was a pack of saltine crackers, 3 popsicles, and a Gatorade. That, for that patient who has hyperemesis gravidarum, is a win. Okay. um, we want to encourage them to intake the foods that they can tolerate. All right. So, nutritional need versus intake. At this point, the intake is the most important. So, we just want to make sure they have something on their belly. We want to make sure they're not becoming severely dehydrated and they're not having any depletion as far as like the electrolytes and everything like that. Okay, so this is how we would educate our patient. This is what we would tell them to do if they were having hyperemesis gravidarum. And then obviously, we want them to keep an accurate account of what they're able to keep in. Okay, so with these patients too, we're gonna tell them, like, if you're not able to get in at least 3 cups of water in 6 hours, or whatever it is, whatever the doctor usually tells them. That would be something they would need to call the office about. We want them to keep us up to date with their intake. We want them to keep us up to date with what they're able to keep down. Okay. We also need to tell them that if they all of a sudden are not able to go to the bathroom or they haven't peed all day long, okay, that is something they need to come in for because we're worried about kidney injury, right? Or something else going on that could be impacting more than just like baby and mom, all right? So they need to be keeping good, accurate record of how often and frequent they're going to the bathroom. Okay, so that covers our hyperemesis and our nausea and vomiting. For the exam, you guys will need to know the difference between hyperemesis and regular nausea and vomiting and those educational points that we just went over. Okay, so we're going to run through the classification of our high blood pressures because so whenever we have a patient who comes in, their blood pressures are going to be separated and put into like different categories. Okay, so we're going to go through the definitions of those. So if a patient has a blood pressure that has higher than 140 systolic or higher than 90 diastolic based on 2 separate measurements, this patient is just has hypertension. This would be qualified as hypertension. If a patient has a systolic higher than 160 or higher than 110 on 2 separate measurements, this is going to be severe hypertension. A patient that develops hypertension at or after 20 weeks of gestation would be gestational hypertension, compared to a patient who has hypertension before pregnancy or appears prior to 20 weeks of gestation. That is chronic or pre-existing hypertension. Okay. These are very important definitions and classifications for you guys to know because we, as the medical professionals, are going to handle each one of these differently based on how our patient presents. Okay. So, if a patient has gestational hypertension, which is what happens whenever it's diagnosed after 20 weeks of gestation. These patients are going to have a different treatment and different regimen than a patient who has chronic or pre-existing hypertension. Someone who comes in who already is on blood pressure medication, when they're first pregnant, is probably already going to be put on aspirin prophylactically. They're already going to have a medication regimen that they're following extensively with their primary care provider and now their OBGYN. But a patient who gets diagnosed with gestational hypertension may or may not need medication. They may or may not need this addressed during their pregnancy. It's something that we're going to pay attention to a lot more closely, but it's not something that we're necessarily already pre-medicating for or they're already on a regimen for, okay? And then if you have a patient who comes into the OB unit and she's in labor and she has a blood pressure of 140 over 90, we consider that high blood pressure and we may give her some medication. But if we have a patient who comes in and their blood pressure is 160 over 110, we're going to be doing a lot more to interfere or intervene with this patient. Okay, so that's why these are kind of split up for you because we treat them all very differently. Okay, so we're going to run through a scenario here. So we have a 38-year-old female. She is 36 weeks pregnant and arrives to labor and delivery for a headache that will not go away with Tylenol. The patient also states, I keep seeing floaters and have even thrown up from it. I do have some swelling and my upper abdomen has really been hurting. My head is really hurting. The nurse notes the patient's blood pressure is 156 over 98. What do we think is happening with this patient?
Preeclampsia.
Preeclampsia. What are our signs and symptoms of preeclampsia?
The headache and the vision,
Mm-hmm.
and then the blood pressure.
Yep, our high blood pressure. Yep, the headache, floaters, high BP. Um, that when she complains of swelling. So with preeclamptic patients, they can swell really quickly. Their legs, their feet, their extremities, their hands, their face. They'll just get really, really swollen. That upper abdomen. When they say upper abdomen is hurting, patients who have preeclampsia have that right, yep, excellent. They have that epigastric pain, that right-sided upper epigastric pain here. It's usually like right under their breast by their rib. All of these things, if I was the OB nurse and she's telling me this, I'd be like, oh crap. We're going to be doing a lot of things for this patient. Okay, so let's run through this because preeclampsia is handled differently than high blood pressure. It's treated differently than high blood pressure because preeclampsia is a systemic type of condition that is going to affect moms in a lot different ways. Okay, so we need to be able to assess our patient and recognize what is normal and versus what is not. This is the criteria for diagnosing preeclampsia. They need to have blood pressures greater than 140 over 190, at least two of them more than 4 hours apart, plus another symptom. Okay? So let's back up for a second. If a patient comes in and her blood pressure is 145 over 100, she doesn't have any swelling, she doesn't have a headache, she doesn't have any of the other symptoms associated with preeclampsia, that patient would just have gestational hypertension. Okay. And she would probably need to be on labetalol PO every twice a day, and then deliver the baby. All right. But if a patient comes in and she has a blood pressure of 140 over 90, you take it again in an hour and it's still 145 over 100. You take it again another hour after and it's still 140 over 90. And she has any of these other symptoms, we are worried about preeclampsia. Okay? So that is the biggest thing I want you guys to know. Preeclampsia is not just high blood pressure. They need to have high blood pressures accompanied by any of these other things. Okay? So let's run through each of them. Proteinuria. They are going to draw on this patient a protein creatinine ratio, which is analyzed in the patient's urine. So these patients, when they come in, are always going to give a urine sample. Okay? What is an elevated PC ratio? Anything over what is concerning? Anything over 0.3 is a concerning PC ratio and would indicate that we're having damage caused from preeclampsia. We are worried about um, this patient. Okay. Elevated liver functioning tests. Preeclampsia, the reason why it's so dangerous is it mostly affects the liver. Okay. So if we have elevated AST and ALT, that's an indicator that this patient is preeclamptic. Edema, including facial swelling. So extreme swelling, pitting edema on the lower legs, lower feet, arms, hands. Renal insufficiency and oliguria. This patient is going to have minimal to no urine output within that hour time frame. We need it to be what, at least 30 mLs, right? Every hour. So this patient is going to have under 30 ml output an hour. These patients will also have thrombocytopenia, so their platelets are going to be low. They'll have those visual changes, that blurry vision. They have headaches that are not relieved with pain medication. And then, like I said, they have that right upper quadrant or epigastric pain. Okay? So these are things that the doctors in the office should be educating their patients on to look out for and to call and report if they experience any of these signs or symptoms. All right? But like I said, and for the purpose of your examination, you guys need to know that preeclampsia is only diagnosed if the patient has elevated blood pressures and then they have another symptom. They don't need to have all of these. They could just have an elevated blood pressure and then a PC ratio of 0.4, and that's enough. That's enough to diagnose them with preeclampsia and admit them and deliver this baby. Because how is preeclampsia resolved?
Having the baby.
Having the baby, but most importantly, delivering what?
Placenta.
The placenta. Do we have currently any tests that can indicate if a patient is going to develop preeclampsia? Do we have any markers?
No, it like occurs late, like third trimester, second or third trimester.
Correct. Preeclampsia is still one of those things that medicine, we have not been able to accurately identify in women who have preeclampsia. Like, there's nothing that flags on that patient earlier in their pregnancy or earlier in their medical history that will indicate that they're going to develop preeclampsia. Preeclampsia is one of those things where it will happen suddenly. The onset is very sometimes random, and we don't know where it's derived from. Okay. We know the placenta, most likely, the placenta is what causes preeclampsia. So if we deliver that placenta, this mom is going to, her symptoms are going to be reduced, her blood pressure is going to decline, and she's going to start gradually getting better and improving. However, there's nothing that will tell us or indicate to us that this patient is going to develop preeclampsia. Okay? Not even with like amniocentesis or chronic villus sampling or any of those genetic testing or anything like that. Nothing like that in so far with any research that's been done has shown that a patient is at a high risk for preeclampsia. Now, if a patient had pre-E with one pregnancy, is she at a higher risk for developing it in another pregnancy? Yeah, for sure. So then we're going to be prophylactic with her treatment. This patient may be on aspirin throughout her entire pregnancy. This patient may have closer monitoring, further, more intense testing or scans. We're going to follow them a lot closer because their risk of developing pre-E is higher. Another thing too, patients who have gestational hypertension or preeclampsia in their pregnancy are at a higher risk for developing chronic hypertension when they're not pregnant. That's the same as it is with gestational diabetics. So if a patient has gestational diabetes, they are at a higher risk for developing type 2 diabetes later in their life, even when they're not pregnant. Okay? So this stuff is going to affect the women in a more like in a long-term sense. It doesn't necessarily only occur and only affect them during the pregnancy. All right. But yes, our biggest thing is delivering that placenta. Oh, another one. These patients with preeclampsia are going to be hyperreflexive. Their deep tendon reflexes are going to be like a +3 and a +4, and they may or may not have the presence of clonus. Okay. So that's another thing. Their deep tendon reflexes they're going to be hyperreflexive with preeclampsia. All right. So you guys need to know this stuff. This is very important. So if a patient has preeclampsia, how are we going to treat them?
Mag sulfate.
What is magnesium used for?
I thought that was to prevent seizures.
It is. Mag sulfate prevents seizures. That is the number one reason why we are going to administer magnesium. We're going to talk about magnesium really extensively here in this PowerPoint. What else are we going to do to treat this preeclampsia? Let's say the patient just came in and she has a blood pressure of 156/95. We haven't gotten any other lab work or any blood or anything drawn. What other medications can we administer to bring her blood pressure down?
The labetalol, is it?
Labetalol.
Labetalol, Labetalol is our number one choice. That's given IV push, most often. Let's say it's a really big emergency. This patient, we need to get her blood pressure down very fast. What's a PO medication we could give them in the meantime while we're working on an IV?
Hydralazine.
Procardia. Procardia is one that we can give. Hydralazine is another medication I believe that we would administer IV, but it can be given PO. So we're going to want to do blood pressure management. Get that blood pressure down. Because high blood pressure is ultimately what is going to cause seizure activity, right? So we need to get that blood pressure down quickly and efficiently. So we're going to manage their blood pressure. Eventually, we're going to administer magnesium. So let's talk about all of these things. So preventing a seizure, magnesium sulfate. You guys were right on with that. MAG is our number one defense for seizure activity. And it's the number one medication that we're going to be administering to help with signs and symptoms of preeclampsia. There's a lot of things that we need to know about magnesium. Okay. It is a central nervous system depressant. So what should we be worried about when we're administering MAG if we know it's a CNS depressant?
Respiratory depression.
Yes, we're worried about respiratory depression first and foremost. So these patients, when we're giving magnesium, magnesium is a high-risk medication, okay? So that means that we need to have 2 nurses at the bedside verifying this medication. With magnesium, what are some signs and symptoms of magnesium toxicity? And I'm not just talking about like adverse effects or adverse reactions, like
Absent reflexes.
absent deep tendon reflexes. Yep. You already said one of them, severe respiratory depression. Decreased level of consciousness, lethargy. Yep. These patients are not going to be alert and oriented times 4. They may even like pass out. Magnesium toxicity would cause that. They're going to have no urine output. So urine output is going to be less than 30 mLs an hour. And severe muscle weakness. All right. So are these patients that are on magnesium a fall risk? Yeah, for sure. So at the hospitals that I've worked at in L&D, we are level 1, so we're really small facilities. Level 1 facilities are not allowed to manage a patient in labor who is on and receiving magnesium because magnesium patients are typically a 1-to-1 or even a 2-to-1 patient assignment. Okay. And some hospitals, they allow their patients that are on magnesium to get up and go to the bathroom and walk the halls if it's appropriate and their magnesium level is within therapeutic index. So at my hospital, and the hospitals I've worked at, whenever they get magnesium, these patients are not allowed to get up. We have to give them a Foley catheter, not only because they're a fall risk, but also because we want to monitor and have accurate in eyes and O's. Okay. So it depends on hospital policy as far as how you're going to allow these patients in like their ADLs and stuff. But for your guys' exam, you really need to know the signs and symptoms of MAG toxicity. So they're not going to have deep tendon reflexes, less than 30 mLs an hour of urine output, respiratory depression, slurred speech, and severe muscle weakness. So when we administer magnesium, do you guys know how we administer it? Typically. So magnesium is given first as a bolus. And it's given, it's given IV. Excellent. So typically magnesium, the patient is going to get a 4-gram to a 6-gram bolus that is administered over 20 minutes. This 20-minute period, you are going to be getting a focused assessment and vital signs every 5 minutes, and you're not allowed to leave the bedside. You have to stay with the patient throughout the entirety of the bolus. Okay. What kind of focused, what things should be what things should be included in our focused assessment for magnesium?
Respiratory.
Respiratory. So we're worried about respiratory rate, but what else are we going to be worried about with this patient? So let's think about it. If this patient is not having any urine output, they are having extreme edema in their extremities. Why would we want to listen to their lungs?
Fluid buildup.
Yes. We are worried about fluid building up on their lungs. We are worried about not only respiratory depression, but worried about that fluid collecting in the bases of their lungs because their third space thing, they're retaining all of that water. Okay. So we need to be listening not only for the respiratory rate, but also for lung sounds to determine and make sure that there's no fluid building up on this patient. So besides respiratory assessment, what else are we going to assess on these patients? So let's go through. We're also gonna do a neuro. So we need to assess their status, like their mental status. Make sure they're ANO times 4 still. We're gonna assess their deep tendon reflexes every 5 minutes when we're doing that assessment. We will assess their urine output, but that's not necessarily something we're doing like in that only in that 20-minute bolus period. So that's not our focus assessment we're going to be charting on. The biggest things is orientation status, deep tendon reflexes, respiratory assessment, and then obviously blood pressure. Okay. Magnesium, like we said, it's a CNS depressant. So it is naturally also going to help with our blood pressure. But the main reason we're giving MAG is not for blood pressure management. It is for our seizure, to prevent seizure activity. Okay. So I don't want you guys to get that confused. The other important thing was our reversal agent for magnesium is calcium gluconate. So if your patient all of a sudden stops talking to you, they are not responsive, their respiratory rate is like 6, and they have complete absent deep tendon reflexes, the first thing you're going to do is shut off that mag. You're going to immediately stop it. You're not going to decrease the rate. You're not going to, call your nurse in first. You're going to completely stop that magnesium. It needs to come off. And then you're going to administer calcium gluconate. That's the antidote. So anytime you're running magnesium, you need to have that at the bedside and available to you. Most hospitals in their Pyxis have the calcium gluconate. It's like in a pack. It's like a magnesium administration pack. So it comes with your bolus dose. It comes with your maintenance bag of fluid. And then it will have the calcium gluconate within that as well. Okay. So that is something we need to know about magnesium. That's very important for you guys to know for your exam. So, why would we have an increased risk of uterine atony and postpartum hemorrhage if a patient has been receiving magnesium throughout their labor?
For muscle weakness,
Sorry, what was that?
because of the muscle weakness, so they won't be able to contract,
Yeah,
maybe.
exactly. So, magnesium, like we said, it's a depressant, it's a relaxant. Okay. So, um, if a patient has been on MAG for an extended period of time, which anything over 12 hours of magnesium administration is an extended period of time on magnesium, okay? These patients are going to be at a much higher risk for postpartum hemorrhage because they're going to have decreased muscle tone, okay? Our uterus is a muscle, right? So we need it to contract, we need it to squeeze, we need it to effectively resist so that it can prevent blood and prevent postpartum hemorrhage. If this patient has been on a relaxant medication, that uterus is not going to contract as effectively. It's going to be boggy. They're going to have a prolonged recovery period, and they're at a high risk for bleed. Okay. So that being said, if a patient is in labor and we're trying to deliver a baby, are we going to have as effective uterine contractions with this patient on magnesium? No, most of
Uh,
the time we're not. Like there's some times where I'll administer magnesium and it'll completely stop a patient's contraction pattern. Okay. So these patients are oftentimes also on Pitocin throughout their pregnancy, throughout their labor. Okay. So the combination of a long-term use of magnesium with long-term use of Pitocin is going to really increase their risk for a bleed. Okay. So these patients, that's why they deliver usually at higher level facilities because you have to have a nurse that's only the nurse for that mom and a nurse that's only that nurse for that baby. Because how do we think magnesium could potentially affect our newborn? What's happening to mom is going to happen to baby, right? Magnesium will cross that placental barrier. So sometimes when a baby is born to a mom who's been on prolonged magnesium use, they might have respiratory depression. They might have poor tone when they're first born. They might be lethargic. Okay. So these babies are going to be a one-to-one patient as well. All right.
So do they always put like if they come in with preeclampsia, do they always start magnesium sulfate prior to delivery?
If we can, yes, because the biggest reason we're doing the MAG is to prevent them from becoming eclamptic, which is when they have seizures. Yes.
Okay.
If a mom comes in, her blood pressure is crazy high and she has all these other signs and symptoms, but she's 9 centimeters dilated and she's about to have her baby, there's a chance that we might only have time to administer magnesium after delivery, but she probably will get magnesium after delivery just to make sure that those blood pressures stay stable and that she's not at a higher risk for seizure activity. But yeah, we do try to start it as quickly as possible if they are diagnosed with preeclampsia. This is like kind of going ahead too. Um, but with this class, I think it's important to try and tie everything together. So we mentioned that babies born with moms who've been on MAG sometimes have respiratory depression, they're hypotonic, and they may be lethargic and have a little bit of neurological decline. Babies, so there's also another time that we are going to administer magnesium that is not related to preeclampsia. So this is just an addition. If a mom comes in preterm labor, like she's 30 weeks, she's going to be put on magnesium sulfate because magnesium sulfate is a neuroprotectant for newborns. Magnesium sulfate will help speed up the development of the baby's brain and prevent them from developing cerebral palsy or other neurological deficits. Okay, so magnesium sulfate is a pretty powerful drug. It's something that we use um, for a lot of different things. But for this, we're talking mostly about preventing seizures, but it's also a neuroprotectant for our newborn infants, our preterm babies. Okay. So all of this stuff you guys definitely need to know for your exam. This will be on your HESI, and you might see it on your NCLEX. All right. So know your antidote, calcium gluconate. Know what our focused assessment is going to be, and know the signs and symptoms of mag sulfate toxicity. Excuse me. So this is for patients who have those high blood pressures, but also have those other risk factors that we mentioned in the slide previous. They also have those other symptoms. When we're managing hypertension, these are the main medications that we can administer, okay? Labetalol, Procardia, and hydralazine. Labetalol and hydralazine are mostly given IV push. Procardia is our medication that we're going to give PO. Procardia is fast acting and it is very effective in bringing our blood pressure down if we cannot get a line started. All right. Labetalol is the one that we use most commonly. That's the one that I usually will give. Okay. So these are for patients just to bring the blood pressure down to a manageable level while we're working on getting labs and starting up that magnesium and getting other orders from our doctors. All right, so we talked about our monitoring for our magnesium. So we mentioned that we give a bolus, which is that 4 gram to 6 gram bolus over 20 minutes. We have to assess and do a focus assessment and vital signs every 5 minutes on these patients when they're getting the bolus. We're not going to leave the bedside. After that, vital signs are still occurring every 15 minutes up until delivery of this baby. Okay. So we're also going to be monitoring our preeclampsia symptoms. With magnesium, these patients, their symptoms overall are going to start to reduce. We're going to start treating and managing their symptoms a little bit more efficiently, but we need to be monitoring them to make sure they do not worsen. And the other thing that we probably will be drawing is a magnesium level to make sure we are in therapeutic range of that magnesium dose. Okay. Signs and symptoms, obviously, of magnesium toxicity. We are always going to be continuously monitoring our baby's heart rate because, like I said, this is a relaxant. It's a CNS depressant. So our baby may not have amazing accelerations on the strip. They may have a couple of decelerations, right? Because this medication is going to be affecting the system for the baby as well. So we need to be monitoring them on the chart. We're getting vital signs frequently. And then obviously we're going to be monitoring our uterus and the tone of our uterus very closely in postpartum period. So we went over signs and symptoms of toxicity of magnesium. Who can tell me like adverse effects of magnesium? Things that like you can tell your patient to expect when they receive magnesium, but that isn't necessarily like oh, we have to shut this off right now. This is dangerous.
Maybe just feeling like tired.
Yes. Mm-hmm.
So,
This may not be like the most medical way to say this, but whenever I have a patient who's on magnesium, I tell them, you guys are going to feel like crap. They do not feel good. Magnesium does not make you feel very good. Patients will typically feel very warm. They may get nauseous. A lot of the times, these patients will throw up. They are overall going to feel like their body feels very heavy. Like it's like harder for them to move around. They may feel like they're kind of almost like moving through water when they're trying to turn or where they're trying to sit up and stand. But those are like the biggest things that you'll see with a patient with MAG. They may feel dizzy with it. That doesn't mean that we have to turn off the magnesium. We just really worry about if they start getting confused or if their speech is slurring. But like dizziness and nausea, vomiting, that is normal with getting magnesium. I really just tell patients like you are going to feel just like nasty. They don't feel very good at all. Okay. But none of that are signs and symptoms of toxicity. Those are Those are normal things that a patient can experience. Hold on one second. Okay, so another thing that's important to note about magnesium and the use of magnesium is when we are administering it and like if it's indicated that this patient should just be delivered or not. Because, like we mentioned, the only cure for magnesia, for preeclampsia, is delivery of the placenta. Okay, so we need to outweigh the risk versus benefit of when we're delivering this patient. So, are we going to deliver them early, or are we going to let them be on magnesium for a prolonged period of time and then let them go further and closer to term? Okay, so if a patient comes in and they are 34 weeks pregnant, they have severe signs and symptoms of preeclampsia, they have high blood pressure, and we are most likely going to be delivering this patient. Why would we want to administer betamethasone? Does anyone know what that is? Betamethasone, or the other word for it, the other name for it is celestone, is a steroid that we administer as two different IM injections, typically 12 hours apart. No, not 12, 24 hours apart, sorry. And it is given to help with fetal lung development. Okay, so when babies are born early, the biggest risk factor for babies is that they do not have enough surfactant developed. Does anyone know what surfactant is or could tell me what that is?
It helps with the development of the baby's lungs.
So surfactant, it is very important for fetal lung development. Surfactant is a substance that will develop in the fetal lungs that allows for that opening and closing whenever babies are inhaling and exhaling to be smoother and reduces the risk of respiratory depression um, or difficulty with respirations. Surfactant makes it easier for the infants to breathe, essentially. Surfactant is not usually fully developed in a newborn until about 38 weeks of gestation. Okay. So babies that are born earlier than 38 weeks, excuse me, it's very common for them to have respiratory difficulty with respiratory effort because their surfactant is not fully developed. Okay. So surfactant is kind of like that lubricant in the lungs that allows for the opening and closing of the lungs to be smoother and prevents any type of respiratory decline. Okay, and it decreases the work of breathing for the baby. So betamethasone is something that we're going to give those moms if they come in early and we're anticipating an early delivery because we want the surfactant to be developed in the baby so that they have less of a risk of a NICU admission, prolonged hospitalization, uh, and any type of adverse respiratory effort. All right. So how do we know that all of these interventions worked? We're going to see the absence of seizures. Their blood pressure is going to improve. They're going to start diuresing. They're going to have decreased edema, and their lab values and their lab results are going to improve as well. Okay. So the biggest thing with how we determine if a patient is going to be delivered versus if we're going to try and keep her pregnant for a little bit longer is based on the severity of her symptoms and her gestational age. All right. If we have a mom who comes in who's 30 weeks pregnant and she has an elevated PC ratio and her blood pressures sit around 140 over 90, that's a patient that we're going to try and keep pregnant for a little bit longer. Okay. If we have that same mom who's 30 weeks pregnant who comes in, she is confused, she has headaches, she's got that epigastric pain, her blood pressures are 170 over 120s. She's had seizures or has had histories of seizures, that's a mom we're delivering that day. Okay. So we just need to be able to use best nursing judgment. And also, that's typically provider discretion. We're not making this decision, right? to see risk versus benefit. Okay. Anyone have questions over this stuff? This is really important for you guys to understand for your exam. Okay. So we have a 40-year-old woman. She's 34 weeks gestation. She has the following vital signs. At 10 o'clock, her blood pressure is 148 over 94. Her pulse is 88. At 2:30, her blood pressure is 150 over 92. Her pulse is 86. What do we do? What are we looking for next?
Ask if she's having any other symptoms.
Yeah, we're gonna like look for other signs and symptoms of preeclampsia. So what are those? What are we asking her about?
Any headache, vision changes,
Yep.
and the right of her gastric pain.
Yeah, would this be a patient that we're probably gonna draw labs on
Mm-hmm.
and get a urine on? Yeah, we're gonna draw her labs. So we're gonna get liver function tests. We're gonna assess her liver enzymes. So we're gonna get an AST and ALT. With these patients, we're getting a PC ratio. We're gonna get a complete blood count. We're gonna assess for thrombocytopenia. Um, and then we're going to assess all those other things that you mentioned. So we're going to look for protein or urine. We're going to do her reflex exam, headache, assess for a headache, and all that other stuff. Visual disturbances. If she's got the epigastric pain, get our lab values, assess for clonus, and monitor her fetal heart tones. Okay. This patient, so does advanced maternal age increase the patient's risk for preeclampsia? It does, yeah. So, advanced maternal age will increase our risk for preeclampsia or issues with high blood pressure, I should say. Not necessarily preeclampsia, but definitely gestational hypertension. Okay. So, she's at risk for that. She's at 34 weeks gestation. Would this patient most likely be a patient we would deliver if she tests positive or has any of these other symptoms? Yes. All right. So we went over hypertension, we went over preeclampsia. Next, we're moving into talking about gestational diabetes. Okay. So let's look at our scenario here. Nadia is a 34-year-old of Indian ethnic origin who is now 24 weeks into her second pregnancy. Her last pregnancy was 7 years ago. Her BMI is 32.4, and her father has type 2 diabetes. GDM was diagnosed during her first pregnancy, and her first baby was born at term, weighing 3.8 kilograms. She has been diagnosed with gestational diabetes during this pregnancy by a 3-hour glucose tolerance test. So, what things stand out to you guys when we're reading this scenario here?
Yeah, it's like her BMI and that.
Her BMI, definitely.
Yeah, I mean, she's already been diagnosed with diabetes.
Right. We technically have a diagnosis already. She did have a big baby in the past, and she has a family history of diabetes. Yeah, excellent. So, you guys kind of answered what we would see, what is concerning versus what is not. We need to assess with this patient, how is she managing her blood sugar? Um, so, real quick, somebody tell me your signs and symptoms associated with hypoglycemia for a patient. What would they report? Or just signs and symptoms that a patient could be developing diabetes, really.
Mm, maybe like weight loss or weight gain.
Yeah. Fluctuations in weight.
Mm,
Um, yep. Frequently urinating. They're excessively thirsty. They may have periods where they're feeling a little bit lethargic or out of it. Um, so, poor glycemic control prior to pregnancy and the first trimester can cause congenital anomalies, stillbirth, neural tube defects, and prematurity. Would we be concerned about these things for Nadia based on her history? Yes. If she has poor glycemic control throughout pregnancy, what else can this cause? The biggest thing with gestational diabetes is the risk for delivering a big baby, macrosomia, a macrosomic infant. What are our risks associated with a macrosomic infant, a big baby?
Too much amniotic fluid.
Yeah, that's a really good point. They can have polyhydramnios. That is a very common occurrence with the gestational diabetics.
Would stillbirth be one?
Stillbirth, yes. Diabetes, it can increase the risk for moms to deliver a stillborn baby. That baby, yes, can be born with hypoglycemia. So our newborn is going to have issues with controlling their blood sugar, which we talk about whenever we get to our newborn stuff. We talk about hypoglycemia in babies a lot because that's something that can affect them pretty severely. With a big baby, also, are we worried about lacerations for mom? We're worried about extensive
Mm,
lacerations. We are worried too about poor uterine tone. Why would we be worried about that? Postpartum hemorrhage. Why would we be worried about that with a big baby?
with trauma?
Trauma. So let's think about it like if we know that mom has a big baby and she has a lot of fluid because she's gestational diabetic, that uterus is stretched to the max. Like that uterus is oversized. So it's going to take a lot more work and a lot longer for that uterus to return to the pre pregnancy size. Okay? So if that uterus is really, really, really stretched, it's going to have a harder time returning and contracting in the postpartum period. So this mom is at an increased risk for a postpartum hemorrhage. This is the same with anything that could potentially make a uterus bigger than what it's meant to be, what the size that it's meant to be. So multiple gestation. If we have twins, and that uterus is expanded to the max to allow for room for multiple babies, we're worried about a postpartum hemorrhage. Yeah, Carolina, you said shoulder dystocia. That is a huge risk factor for a macrosomic infant. Shoulder dystocia is a labor and delivery emergency. Okay, that's when that baby is coming down in that final part of the delivery. The head has been delivered, and the anterior shoulder gets stuck under mom's pubic bone. What is associated for the newborn with a shoulder dystocia? What are we worried about for that baby? We're worried about a clavicle fracture. Sometimes we're also worried about a brachial plexus injury, any type of injury to that anterior shoulder, because that is a traumatic delivery. That would be a traumatic birth. Does anyone know how we correct a shoulder dystocia? This is bonus if you guys get this stuff because I don't think we cover it until next week, I think, is when we go over the shoulder dystocia.
Like when it's happening or after?
When it's happening, if you are the bedside nurse and your patient, that baby's not delivering, and your provider says we have a shoulder dystocia, what do we
Or
do?
you try to like reposition the
Yes,
baby, or is that where they would use the vacuum? Or like the thing on their head, or no?
so we can use a vacuum, but we don't want to pull too hard because that will increase the risk for a clavicle fracture. There are some maneuvers that we do for shoulder dystocias. The one is called a McRoberts, and the other is a Gaskins maneuver. So the McRoberts maneuver is when you have a nurse on one side, a nurse on the other side. You extend the patient's legs all the way out, and then you bring them back very forcefully to her chest to try and dislodge that shoulder out from under the pubic bone. That is a way that we can correct shoulder dystocia. The Gaskins maneuver is just putting the patient in hands and knees. Okay. And like I said, this is moving a little ahead of things, but this is stuff that you guys will need to know for exam two. Okay. So with a macroscomic infant, we are worried about extensive lacerations for mom. With lacerations for mom, if they're not repaired, that can be something that can cause a hemorrhage, right? We talked about that at the beginning of class. An unrepaired perineal or cervical laceration can cause excess bleeding. And then we're also worried about a shoulder dystocia and postpartum hemorrhage with a big baby. All right. If she is not controlling her blood sugar throughout her pregnancy, it will cause neonatal hypoglycemia. We go over this very extensively for exam three content. I don't think we go over these things until week 7 or 8. Um, but neonatal hypoglycemia is one of the biggest adverse effects that can happen to a baby when they're born, especially like bigger babies or babies born to gestational diabetic moms. Okay. This will also cause respiratory distress syndrome in a newborn, and that is tied hand in hand with hypoglycemia. So, with a hypoglycemic infant, we're just going to go through this here very briefly, nothing too extensive. You have a baby who is metabolically acidotic, right? So, if we have uncontrolled blood sugar, we are going to have compensation from the rest of the body to try and correct that metabolic acidosis and correct that hypoglycemia. So, what that means is that our respiratory effort is going to increase. We are going to have an increase in the intake of carbon dioxide. We are going to have an increase in respiratory acidosis, which is going to lead to respiratory distress. Okay. So oftentimes in newborns, realistically in adults too, right? If you have something going on in your body that is sending you into an acidotic state, you're going to have compensatory mechanisms that are kicking in from other parts and other systems of the body that is going to try and correct that and put you into something else. Okay, so that's the exact same thing as it is with a newborn. You have a baby who is hypoglycemic. That baby is going to start trying to compensate for that hypoglycemia, that metabolic acidosis, and it's going to put them in respiratory distress or respiratory acidosis. Does that make sense? Okay. So hypoglycemia or poor glycemic control in a mom throughout her pregnancy puts the baby at extreme risk. All right. So this is also kind of looking ahead. If we have a baby who's hypoglycemic, what are we going to do to help them, to fix them?
Educate them.
Increase their nutrition and give them fluids.
Yeah, we're going to feed the baby. We're going to try and give them either colostrum or formula. If that baby is in is also in respiratory distress, we're not going to try and give them anything by mouth because they could aspirate. So we may need to give them IV fluids. The IV fluid that we typically give for a newborn is dextrose 10. So we give them D10. Okay. But this is looking way ahead, guys. So just to get your minds thinking to kind of connect everything together. All right. If a mom has gestational diabetes, this predisposes her and puts her at a higher risk for preeclampsia, ketoacidosis, infection, and hydramnios. So, like you said, Shantae, with patients who have high blood sugar and they have uncontrolled gestational diabetes, they are at a higher risk for developing polyhydramnios or having too much fluid. Okay. I've had it before where a mom will come in who did not have prenatal testing, did not have any prenatal like labs or anything like that, did not do her glucose screening. And we break her water, and there is so much fluid. It's like going over the edge of the bed. It just continually pouring out. That she's has polyhydramnios. Those patients, it's probably safe to assume, have underlying gestational diabetes. Okay. Not too much else will cause polyhydramnios. Sometimes it can occur independently. Um, but we see that a lot with gestational diabetics. Okay. So we also need to know our signs and symptoms if a patient is in DKA. This should be a refresher for you guys after med surge. Okay. Um, but the patient will have that fruity breath. They're going to be extremely thirsty. They're going to pee all the time. They'll have abdominal pain, a headache, dry and flushed skin, weak and rapid pulse, lethargy, drowsiness, and their blood sugar is going to be over 200. All right. So you guys will need to know that for sure. Can a patient be on an insulin pump while they're pregnant? Or if they're laboring? They can, yes. These patients are not patients that are going to deliver at my little tiny level 1 LDRP, but um, if they come in to the ER, they're 32 weeks pregnant, and they're in DKA, these patients will be put on an insulin pump. And most of the time, that baby's probably not doing too well if they're in DKA. So we need to put them on the monitor, and these are patients that are going to be assessed very extensively. Okay? Questions on this? Awesome. How are we going to correct this? How would we educate our patient if they are gestational diabetics to maintain their glucose levels?
Checking your glucose levels frequently,
Yeah, check your blood sugar.
getting the diet,
Mm-hmm. Yeah, Alexis, walking after meals, increasing their exercise. This is the same education we're going to give to a patient who is at an increased risk for developing type 2 diabetes. Lifestyle changes, okay? Exercise, diet, monitoring their blood sugar. If they have to be on medications, we're going to educate them on the medications that they need to take. Um, so, daily glucose checks. Exercise. That does not need to mean like, okay, go out and train for a half marathon. That's like, go out and walk for 20 minutes a day. If you sit at a desk for your job all day long, every hour, make sure you're getting up and walking to refill your water bottle, right? Diet, cut back on sugar, okay? And then any medication, if they are required to take insulin, or if we do prescribe them metformin, which is something that is very commonly prescribed in pregnancy for gestational diabetes. How do they take this medication? What are the signs and symptoms of the medication? Just because you are on insulin does not mean you don't need to check your blood sugar. Some patients think that if I'm on insulin, I don't need to check my blood sugar because my blood sugar is going to be fine with my medication. It's like, no, we need to educate them like, this is when you should take your medication versus when your blood sugar is too low, you don't need to take your medication, right? So, extensive education. Just like with any diabetic patient, that's probably the most important thing for these patients. Our insulin requirements. So, insulin requirements for pregnancy will fluctuate based on the trimester that the patient is in. Can anyone tell me, like, when we increase the insulin versus when we don't? So, we decrease their insulin requirement in the first trimester, and then we increase it in the second and third trimester because they are more insulin resistant because that baby is bigger. Okay. So the glycolic demand of a newborn is going to increase in the second and third trimester because that is when the baby is putting on the most of their body fat and when they're gaining the most weight. Okay. So in that first trimester, our baby is at the beginning of development. Okay. So their glycemic index and their demand is going to be like next to nothing. This first trimester is also usually when moms gain the least amount of weight during their pregnancy. But once we get into the second and then third trimester, as that baby's glucose demands are increasing, we need to increase the mom's insulin to compensate for that. Okay? And then after the baby's delivered, we can either completely stop the mom's insulin or drastically decrease it. Okay? Because her glucose demand is not going to be nearly as high as it was whenever she was pregnant. This is the same concept for patients who have hypothyroidism or any other type of metabolic or autoimmune disease. So, like in the first trimester, we typically just treat them as you normally would when they're not pregnant. And then as the pregnancy progresses, we need to increase the medication that patients are on because the baby is requiring more. Okay? We're monitoring our baby. So we're going to be doing frequent non-stress tests. We're going to get ultrasounds and we're going to encourage moms to do daily kick counts. Why are we going to be doing these things?
Make sure the baby's not in distress. Make sure the
Yeah.
baby's alive.
Yeah, because this patient is automatically a high-risk pregnancy. We also want to do ultrasounds to measure fetal growth. So we want to make sure we're not going to have a macrosomic infant. And we're also going to do frequent ultrasounds to measure amniotic fluid to evaluate for that polyhydramnios. Okay. With ultrasounds, though, the measurement of babies on ultrasound, we have to account for a pound or two of it being off. We still are not able to very, very accurately pinpoint a baby's exact weight based on ultrasound. Okay. So if a mom comes in and she's 37 weeks and her baby is measuring at 7 pounds, that could potentially be a 9-pound baby, but it also could be a 5-pound baby, right? So we can't accurately just diagnose macrosomia based on that. The best indicator of fetal size and overall development is our fundal height and our fundal measurements that we do at each visit, which we talked about those for the exam 1 content. Those start at 20 weeks, and it should match up to the mom's gestation, the amount of centimeters that fundal height is measuring. Okay. Our daily kick counts are very important, especially towards the end of pregnancy, because these patients are at a high risk for stillbirth. As the bedside nurse, you should be preparing for a difficult delivery, so a shoulder dystocia, a macrosomic infant, or potentially cesarean if that baby is too big and we're not progressing as we need to be, okay? And then we're monitoring our newborn, mostly for hypoglycemia, respiratory distress, and any birth injuries, like we mentioned, the clavicle fractures or brachial plexus injury. All right. So let's go through some questions here. A woman who is 22 weeks gestation had a C-section for both of her previous pregnancies. The woman experiences bright red, painless vaginal bleeding. On her arrival at the hospital, what condition should be assumed unless ruled out?
Preeclampsia.
So let's look closely. This bright red, painless vaginal bleeding is probably the most concerning. What are we worried about with that?
I don't know. One is painless and one is with pain, isn't it?
Placenta previa.
We're worried about a
And
placenta.
the previous is painless.
So what was your question? I'm sorry, I didn't hear you.
It's okay. I answered it. I got it.
Okay. So, you guys for your exam will need to know the difference between a placental abruption and a placental previa. Okay. A placenta previa is a condition that occurs whenever that placenta grows over the cervical os, the opening of the cervical os. So in this picture here, you can see it. You have your cervix, and then here you have the placenta growing over and covering that cervix. Can a patient deliver vaginally with this? No. They cannot. So patients that have placenta previas oftentimes are C-sections at 38 weeks, sometimes even sooner. Okay, because we do not want this patient to have contractions. We do not want her to start labor. We do not want any type of anything like that to happen, because what typically will happen is the placenta will start to separate, and the placenta will try to deliver before the baby. Okay, and if our placenta is starting to come off of the uterine wall, that is going to decrease oxygen to baby. We're not going to have perfusion. Baby is going to be in distress. Okay. We can have a complete placenta previa, and we can have a partial placenta previa. A partial placenta previa, like in this picture, the entire placenta is not at the base of the uterus. It's not covering the cervix. You only have a small portion of that placenta that is covering the cervix or partially covering that cervix. A complete placenta previa, this whole placenta would be down over the cervix. Okay. The biggest indicator that a patient has a placenta previa, they're going to have spotting and they're going to have bleeding throughout their entire pregnancy. All right. So, if a patient has spotting in her first trimester, we rule out that she's having a miscarriage. We rule out spontaneous abortion. This patient will most likely get an early anatomy scan to identify if the placenta is developing over that cervical os. Okay. And then if it doesn't move, then she'll be diagnosed with a placenta previa and she's automatically a C-section. Okay. If a patient comes in and says bright red, she's having bright red, painless vaginal bleeding, that should be the first thing that we're worried about, is that she has a placenta previa. Are you going to check this patient's cervix with are you going to perform a digital exam?
No.
No. Why wouldn't we do that?
You don't want to hit the
Might
placenta.
rupture something. I don't know.
Yeah,
I
you're
don't know.
you're gonna hurt something. You're gonna rupture. You're worried about a placental eruption. So, anytime a patient has vaginal bleeding, you should always call the doctor first so that they can come in and do a speculum exam before you're just putting your fingers up there, because you could hit something, you could rupture something and make it worse. Okay. So we're not going to perform cervical checks on a placenta previa. Right? The biggest difference between a placenta previa and a placental abruption. Patients that have a placental abruption are going to be in excruciating abdominal pain. They're feeling like my stomach is being stabbed. It is very, very extreme. It is intense. It does not go away. It's not like a contraction where it'll come and go. It is constant. It's constant pain that keeps getting worse and worse and worse and worse. These patients will also have bleeding, vaginal bleeding, but it's typically dark red, and it's usually a lot heavier than with a placenta previa. Okay. So we can determine a placenta previa via ultrasound. We don't want to do vag exams. So what are we going to anticipate our treatment plan to be for the patient who's having a placenta previa?
Well, they're going to have to give birth C-section.
Yeah, they're going to have a C-section. But we need to rule out first if she's actively laboring or if this is just she's having a little bit of spotting and we can eventually send her home. Okay. So if this patient comes in and she's 28 weeks gestation and she's having bleeding and we have not had a diagnosis of placenta previa, we want to try and stop the bleed. And the most effective way of doing that is bed rest. She's going to be on extensive activity restrictions. So she's not going to be allowed to lift. She won't be able to really go on walks or do too much exercise. Bed rest is going to be the most important for this patient. No sex or anything in the vagina. This patient obviously is not going to have cervical exams. Excuse me. But mostly we need to get that diagnosis. So we need to figure out, is this a placenta previa or what's going on? We're going to monitor her bleeding, monitor our fetal heart rate, get her vital signs, obviously, make sure she's not having any uterine contractions. If she is having uterine contractions and she's term, we're most likely going to just do a C-section and deliver the baby, right? We're going to notify anesthesia as well as our NICU team. We're going to make sure if she is going for a C-section, we're getting our consent form signed. No vag exams, type in cross-match blood products to have on hold. And then we need to have this patient have 2 large bore IVs because we most likely will need to administer blood or blood products if this patient has been bleeding for a while. Okay? Oh, let me go back so you guys can get this. So this is our anticipated treatment plan for a placenta previa. With anything with labor and delivery, like I said, we're weighing risk versus benefit. So if this patient's 35 weeks pregnant and she comes in with bleeding, the baby looks good. We've administered betamethasone for that lung development. She's still bleeding. She's having abdominal contractions. We're going to deliver that baby. That baby is just going to be delivered. Okay? If a mom comes in with a placenta previa who's 28 weeks of gestation, we don't want to deliver her right then and there because that baby is not ready to be delivered. Okay? They're not old enough. They have not had enough time to develop in utero. So we're going to try these other things, the bed rest. We're going to try stopping her contractions if she's having any. You know, this is a patient that might be admitted to a long-term hospital and be monitored for the next 6 weeks until we determine that baby has had enough time to develop. Okay? All right, next question. A woman who is 32 weeks gestation experiences a sudden onset of intense localized abdominal pain with dark red vaginal bleeding after she fell down the stairs. On her arrival, her fetal heart rate tracing shows late decels. What condition are we worried about?
Placental abruption.
We're worried about abruption. So with abruption, this picture here is great. The placenta is coming off of that uterine wall. It's detaching from the uterine wall. So with placental abruptions, what is our main concern?
Bleeding.
We're worried about bleeding, but Capria, that's awesome. We're worried about fetal hypoxia because our placenta is not going to be able to circulate. We're not going to have adequate perfusion if it's actively breaking off from that uterus. That's going to disrupt placental circulation. It's going to lead to fetal hypoxia, fetal distress, and potentially fetal death if this goes on for too long. Okay? Placental abruptions is one of the #1 OB emergencies. Okay? This patient is going back immediately for a stat C-section. Like, she walked through the door, we diagnosed a placental abruption, that baby needs to be delivered within 10 minutes. Okay? These babies that are born from a placental abruption, they are definitely going to need resuscitation. Okay? So these infants, you need to have your provider at the bedside, your newborn provider. You want a respiratory therapist. You want at least 2 NRP certified nurses at the bedside with you because this baby is not going to be in good shape whenever they're delivered if we have an abruption. What caused this woman's abruption?
The fall.
She fell down the stairs. Yeah, she fell down the stairs. So typically with an abruption, you can have spontaneous placental abruptions. They happen. They're very rare. Typically, placental abruption is caused by some sort of abdominal trauma. Okay? So, motor vehicle accidents, domestic abuse, domestic violence, any other type of abdominal injury can cause a placental abruption. What is something else that can potentially cause placental abruption? We haven't talked about this too much either. A big one is drug use. If a mom abuses cocaine use in pregnancy causes placental abruptions. Okay? And like I said, this is an OB emergency. I one time had a patient who came in. She was 28 weeks. She was complaining of severe, severe, severe abdominal pain. She was a known drug addict. I forget what drug she was using. Um, she said she had taken drugs in the morning. She was abrupting. We had to take her back for a stat C-section, and that baby had a full resuscitation and was transferred to the NICU. Okay? So these things will happen very quickly. You take them back immediately for a C-section. All right, so let's look at the differences here between our placenta previa and our placental abruption. With elevated fundal height, we're going to see that with placental abruption because that uterus is filling with blood. Okay, it's going to start increasing and growing that uterus. So the elevated fundal height is associated with placental abruption. I'm just going to go through these with you guys because I want to make sure we get to everything. Severe and steady pain would be placental abruption. A firm, rigid, board-like uterus will be your placental abruption because it's filling with blood, right? Painless bleeding will be your previa. The internal cervical os partially covered by the placenta is your placenta previa. Total placental separation from the uterine wall with massive bleed is a placental abruption. Bright red bleeding is placenta previa. Dark red bleeding is a placental abruption. A soft and relaxed uterus would be your placenta previa. That is not going to have any effect on your uterus whatsoever if you have a placenta previa. And then your placenta separating at the edge and blood escaping vaginally, that's going to be your abruption. Okay? For your exam, you guys need to know the difference between an abruption and a previa. Okay? Do we have questions on this? All right. So for an abruption, our number one thing is we're going to control the bleeding and prepare for a C-section. What are we doing for that? We are notifying our surgical team. We are getting our physician there. We are getting our surgeon there. We're going to type in cross-match blood, and we're going to have uterotonics ready. This patient who had a placenta abruption, are they at an increased risk for a hemorrhage, a postpartum hemorrhage? For sure. Yeah. They already were bleeding before they even delivered this baby. Their uterus is going through a super traumatic event. So they are going to be bleeding extensively after the baby is delivered. So we need to have all those medications ready and available in the OR with us to administer to the patient. So we're preparing for a hemorrhage. We have those 2 large bore IVs. We need to make sure our vital signs remain stable and administer IV fluid and blood products if necessary because we need to maintain tissue perfusion. These patients are going to be in bad shape, okay? Like I said, they're already going through a very traumatic event. Their uterus is under a lot of strain. They're already bleeding prior to delivery, so they're going to be bleeding extensively after the delivery of the baby as well, okay? We're monitoring those signs and symptoms of hypovolemic shock that we went over at the beginning of class. So we're looking at their heart rate. Are they tachycardic? How is their blood pressure? Is it super low? Are they dizzy, lightheaded? Are they confused? Are they pale? What's their urine output? Is their skin cool and clammy? And then we're monitoring for signs of DIC. I've only been, knock on wood, a part of 3 placenta abruptions in my career, and every single patient has had to have at least 4 units of blood transfused back in the OR, and most of the time they get what's called a Bacri balloon, which is when we put something up into the uterus to maintain uterine tone, okay? It's basically a mechanical device that contracts the uterus for the patient, okay? These patients are in the hospital for an extended amount of time. They're 1-to-1. Sometimes these patients will go to the ICU or need to be transferred to a higher level of care. Abruptions, it's a massive bleed. They lose lots and lots of blood. Okay. All right. Let me stop sharing here. So that information that we just went over is going to be on exam 2. Okay. Some of that stuff you guys are going to see on your quiz next week that you're going to have at the beginning of class. It's really important for exam 2 to know the differences between those things that we talked about. So your nausea and vomiting in pregnancy, your hyperemesis gravidarium. Know the difference between those. Know the difference between your placenta previa and your placental abruption and how each would present and how we would treat it. Okay. With preeclampsia, when does preeclampsia develop to eclampsia?
After 20 weeks.
Seizures.
If the patient has a seizure. So preeclampsia just means prior to seizure activity, really. Okay. If a patient has a seizure, automatically she's eclamptic. Okay. We talk about that more extensively in week 6, eclampsia. So Professor Luminosa will go over that with you guys in class next week. Okay. So let me pull up because we still got about 5 minutes here. So don't forget this week, you guys have the OB Math 2 assignment due, as well as your preeclampsia sim chart assignment. Do you guys want me to send you the link to the Kahoot game for last week? Okay, I'll send that to you guys. Does everyone know how to get to the course cafe in Canvas? Okay, I'm gonna just show you guys that really quick because we have like a couple minutes and then we'll be done for the day. I'm gonna show you where you can go for the course cafe if somebody hasn't found it yet. Because I'm gonna post the Kahoot games in the course cafe for you guys to practice. So it should be here for you on your home screen. Whenever you see this welcome page, scroll down, go here to course cafe. And then you'll see it. So this is where I had posted the leftover stuff that we didn't get to from week 2, I believe, or week 3. Yeah, week 3. So later today, I will post those Kahoot games for you guys if in here in the course cafe. If anyone wants extra review or you want to just like meet with me to go over your exam or your quizzes, I can't go over quiz 3 until everyone has taken it in all the other sections. So we would have to wait until the weekend. But I'll always go over those things with you guys because I want you to understand like what you didn't understand or like where you went wrong. Because that kind of stuff you may see on the exam or on your HESI. Okay. If you received an email from me after exam 1, please respond and try and set up a meeting with me before the end of the week. Otherwise, we'll just have you touch base with Professor Luminoso. Okay. Okay. So I think that's really it that we need to go over. Let me start my